This is the second lecture for female anatomy. So we're going to move out of the ovary and move into the ductwork that I'd like to talk about. So we're going to start with the uterine tubes. They are a tube with many names. Perhaps you've heard of the term fallopian tubes from a time when you took this course previously, or oviducts. All three are accepted names. I'm going to stick with uterine tube. It is my favorite and most descriptive of this structure. So, right, we have a posterior view of our uterus here. We've already introduced our female gonads, the ovaries, and now we're going to focus on these two things here, the uterine tubes. We can divide the uterine tube up into a number of structures. The infundibulum is the portion that is closest and just about making contact with the ovary. The infundibulum contains these finger-like extensions called fimbriae. Now, there is not a solid connection in the female system like there is in the male system between their network of ducts. So when that egg is ovulated, okay, the fimbriae are going to act to kind of pull and sweep and create a little bit of a current to pull the egg in the right direction, because there's not a solid junction here, right? The egg could possibly wander off into the body cavity, but the fimbriae should help it move in the right direction and get the egg into that first part of the uterine tube, the infundibulum. From the infundibulum, this next portion is called the ampulla. Ampulla, just like in the male system, this is just a funnel-shaped part of the structure. The ampulla, incidentally, is often the site of fertilization. So we'll talk about that in later lectures, but now we know exactly where most likely the sperm cells need to be swimming to whenever they enter, right, the female reproductive system. They've got to go all the way through the uterus, right, through the uterine tube, and they're going to arrive here. So that's going to be a pathway for sperm cells. The final portion that we need to talk about for the uterine tube is just the isthmus. So isthmus just refers to that this is a skinny structure. You can see islands and land masses that are kind of called isthmus, right? Just a skinny structure here. Okay, and then if we cut open the uterine tube, we can take a look at what's inside, and we can see the lumen in here is pretty skinny. It's kind of the star-shaped structure here. Okay, and we can see that there are lots of supporting tissues, lots of layers here in the uterine tube, really facilitating the job that needs to be done. Okay, that egg and sperm cells, they kind of need to be swept in the right direction. So there are lots of cells there with little hair-like projections called cilia that are directing movement. I want to mention something about an ectopic pregnancy. Ectopic simply means out of place. And this happens in 1 in about 450 pregnancies. And depending on how out of place the pregnancy is, this can be life-threatening, and this is concerning. So often, the ectopic pregnancy occurs in the uterine tube. So remember what I just said before. The site of fertilization often happens in the ampulla. And it is the job of the united egg and sperm to then move through the isthmus of the uterine tube and then pick somewhere, anywhere in the uterine lining, wherever you would like to implant. This doesn't always happen. So if the egg just implants right where it gets fertilized and goes nowhere, now we've got a problem. Now we've got an embryo in the uterine tube. The uterus has lots of room to grow, lots of space. The uterine tube does not. So at about 12 weeks, we reach the point at which the embryo is starting to get big enough that it can't live in the uterine tube anymore. And unfortunately, there's really not a way to get the embryo and move it. You're going to lose the embryo. You can't leave it where it is, though, because it's also going to kill the mother. She's at a very high risk for hemorrhage and death. This is an actual image of a surgery. Someone's looking at this pregnancy here that is in the uterine tube. So it's an ectopic pregnancy, so you can get a little bit of a view there, kind of see what's going on with some of these tissues. Okay. The uterine or tubal pregnancy is often what happens. There is this crazy scenario where the baby could implant somewhere in the abdominal cavity. And even though that's even a less appropriate place for an embryo to form, there's actually more of an opportunity for survival here. Again, just with a tubal pregnancy, there's a limit to how big the embryo can grow before this tissue dies. Explodes, bleeds, and kills the mother. If the embryo kind of wanders out here into the abdominal cavity, it might be able to find a place where it can grow. The best treatment for an ectopic pregnancy is therapeutic abortion. These are very much wanted pregnancies often by the parents, but there is too great a risk to the life of the mother to continue them. Let's move on to the uterus. So this is the place we should be implanting our embryos and allowing them to grow. It's a very thick muscular chamber. So we can see our uterus here, and it's been sectioned away. We can cut and see here, and look how thick that wall is. And most of that is all muscle, okay? And it's going to be able to really grow and expand. There are a couple anatomical regions I want to draw your attention to. So the top of the uterus is called the fundus. Fundus just means dome shape. Your stomach has a fundus as well. Okay, the body is going to be this middle part. The isthmus, again, isthmus just means a skinny part. And then the cervix is of particular interest. The cervix is the bottom part that divides the uterus from the vagina. And there is a tiny little opening there called the cervical os. This is where the embryo, well, it's going to be a fetus by the time it's fully grown. That's where the fetus is going to pass through. This is where any ovulated but unused, unfertilized eggs are going to pass through. And then we're going to talk about these internal layers of the uterus, which create a lining that is shed monthly during menses if pregnancy does not occur. So all of your menstrual fluid is also coming through here. And then the only thing that's going the opposite direction, we just mentioned before, sperm cells have to be able to find their way into the cervical os and figure out which way they're going to swim once they get through the uterus and into the uterine tubes. I just want to make a comment about uterine positioning. So these are sagittal sections from the side view here. Okay, so about 80% of women out there have a anteverted uterus. Anti just means for. And that means that the uterus is kind of folded over towards the front of the body, and it's sitting on top of the bladder here. A portion of women, about 20%, have what's called a retroverted uterus, which is flipping back towards the back of the body. So anything retro is like back. And so the retroverted uterus is flipped towards the back. There's no impact on fertility, but some women might report dyspareunia, which is pain during sexual intercourse. So if you find that you don't enjoy or don't like certain types of sexual intercourse, just switch your position. Perhaps your uterus is in the retroverted position, and there are different sexual positions you might enjoy versus someone with an anteverted uterus. The uterus doesn't always stay retroverted. It often pops into place during pregnancy because that uterus is really going to need to fill this space as it grows and accommodates that ever-changing and ever-growing embryo. Let's talk a little bit about uterine layers. So as I mentioned before, now that we're looking at, again, the frontal view of the uterus, and we can see that there is a very thick muscular wall. There's this inner lining, and then there's also an outer covering. The outer covering is simply called the perimetrium. Peri just means outside. Not a lot goes on in the perimetrium. Myo means muscle, so this is the thick muscular layer of the uterus. This is the thing that's going to contract and really help push the baby out of the body. It also contracts a little bit during menses to help release menstrual fluid. It also contracts a little bit during orgasm and gives us that pleasant, good-feeling uterine contraction. The endometrium is where everything gets very interesting. This is the most highly variable layer, meaning that it's changing constantly. The endometrium really has to be in tune with what's going on at the ovary. It wants to be at its thickest when ovulation is happening, so the embryo has a nice place to go. And if we don't get pregnant, we need to shed that endometrial lining and prepare for next month. So that's when I say variable, I mean that it changes a lot. Let's take a look. These are tissue sections now of the endometrium. So now we're looking at this from a slightly different view. We really can't see perimetrium. We can see myometrium here at the bottom. And then we can look here. This is a section of uterus. This is also a section of uterus. So what happens with these endometrial layers, okay, is that there's always this bottom layer that is growing and regenerating. Okay, this is the basilar zone or zona basalis, and this is what you always have in terms of endometrium. So that layer always exists. So number one, that layer is always there. Number two layer of the endometrium is called the functional zone. So that functional zone is going to grow and change. It's either going through a proliferative growth phase to increase in size and build up and get ready for pregnancy, and then it's going to increase in size even more. And then it's that functional zone that will actually degrade and be shed as menstrual fluid if pregnancy does not occur. One other thing I want to make a comment on, we will come back to menstrual cycle and we will talk much more about this in the future, but I just want to make a little bit of a note on endometriosis. Okay, so that uterine lining should shed and just leave through the cervical O's and be shed monthly. If that tissue finds its way into another portion, if it backs up into the uterine tubes, that can be quite painful. That can affect fertility, and it affects about 10% of US women, typically younger women. This is a problem. Okay, and then one comment on cervical cancer. Okay, so the cervix, that was that entryway from the vagina into the uterus. Okay, your cervix is very important. That's really going to regulate what comes into and out of the uterus, and that cervix needs to be very thick and strong to hold that baby in place. So cervical cancer can be really threatening to someone's reproductive health. Women are often tested annually for this. This is the Pap smear test. It was invented back in 1942 by Dr. Papanicolaou. Right? Say that one 3 times fast. That's why we just call it the Pap test. And that's available to look for any type of precancerous cells, any extra cell growth or abnormal growth on the cervix. So what happens is if you do have cervical cancer, is a huge risk to your fertility because often the only treatment is a total hysterectomy, which is removing the entire cervix. And guess what? The cervix is attached to the uterus, so you're going to lose that too. So now you have nowhere to grow an embryo. So your reproductive days are likely over if you have cervical cancer. Now, I want to make a bit of a claim here, a little bit of cause for the Gardasil vaccine. Cervical cancer has been linked to something called the human papillomavirus. It's a sexually transmitted disease. And the human papillomavirus, now there are many, many types of human papillomavirus, like 100 different strains. About half of US women over 35 are infected with HPV. Now, of those about 100 different strains of human papillomavirus that women like myself who are over 35 are, flip a coin to see whether we're infected or not, there are 4 of them that are really known to cause either cervical cancer or actually genital warts. So now we can go out and you can actually get a vaccine. Okay, for the Gardasil vaccine, which should reduce your risk of cervical cancer, and that it's going to eliminate your chance of contracting these few types of human papillomavirus. I have a little bit of a controversial vaccine here because of the fact that this disease is only transmitted sexually. Some parents pushed back and really didn't want to give their children the vaccine because they felt their children shouldn't be having sex. I can tell you that abstinence-only education is not realistic and not often helpful. So it is in your best interest, if you don't want to have cervical cancer and you don't want that risk of losing your uterus and cervix, I would highly recommend getting the vaccine. Now, shortcomings of this vaccine is that it is indeed only protecting against those 4 types. What I'd like to do this week is have a discussion on cervical cancer, and I'd like us to talk about whether or not to get the Gardasil vaccine. I'd like to talk for a minute about cervical cancer. This is a particularly deadly cancer. I'd like to take a minute to talk about cervical cancer. This is a particularly deadly cancer, and it has huge impact on female fertility because if the cervix is cancerous, the cervix is attached to the uterus, the treatment for getting rid of the cancer is often a total hysterectomy, removal of the cervix plus the uterus. Now this test, or cervical cancer, can be tested and screened for. Most women often go to the doctor, their gynecologist, once a year to get what's called their Pap test or their Pap smear. This was actually, Pap is shorter for this physician's last name, if you were curious as to why they call it that particular test. What they're looking for is abnormal cells growing where they shouldn't be, any sort of abnormal growth, which we're going to term cervical dysplasia, to look for these precancerous cells. Right, so one thing that is known to cause cervical cancer is the human papillomavirus, or HPV. Okay, HPV is a sexually transmitted disease. Men can have it, women can have it, but it's really the women that get the short end of the stick here, because what's going on here is that, you know, it's our tissues. Men don't have a cervix. It's our tissues that are affected and becoming cancerous. A recent statistic said once that half of US women over 35 are infected with HPV. Now, let me be a little bit more specific about HPV. There are about 100 types of HPV. Not all of them are going to cause cervical cancer. Some do, some don't. There is now a vaccine called Gardasil available, and that vaccine is going to be able to treat, or actually going to be able to prevent you from getting a couple types of HPV. So not all 100, we're not safe from all of them, but there are 4 particular types that the vaccine has been developed against, and those ones are known to cause cervical cancer and also genital warts. I do have this kind of controversial cartoon in here, and that's going to segue us into the conversation I'd like us to have on the discussion board. Who should get the Gardasil vaccine, and when should they get it? Okay, it's going to prevent cervical cancer, but the only way to get HPV is to have sexual intercourse. So some parents feel uncomfortable giving their children a vaccine that is protecting against sexually transmitted diseases if they're younger. But when are you going to do it, right? You have to give the vaccine before you're going to have sexual intercourse if you want to be protected. And again, both men and women can have HPV. It's just women that are most often affected with the cervical cancer because men don't have a cervix. So we can argue some of those points and discuss them a little bit more on the discussion board this week.